Okay, welcome everyone to our Friday seminar. And we have a special occasion today. This is a joint seminar, joint between the School of Community Health and the Center for Transportation Studies here at Portland State University. And this is in recognition of our joint MPH and MERP planning degree. So we're trying to do more joint activities, and this is a great opportunity for today's event, which is also sponsored by OTREC and the College of Urban and Public Affairs. So my name is Jennifer Dill. I'm a faculty member here at PSU and director of OTREC, and along with my colleague, Professor Chris Monsieur in civil engineering, we help co-organize this weekly seminar. So welcome everyone. We have a lot of new faces because we have a lot of folks from community health, the public health, as well as planning and engineering. So I'm very happy today to introduce our speaker. Before I do want to let everyone know, because we have a lot of new faces, we do webcast the seminar. So there are people watching us live on the web right now and archived into the future. And once we get to time for questions and answers, you need to use the microphones that are on the tables when you ask the question, and keep the touch button, hold your finger on the touch button, keep the red light lit while you're asking your question. If for some reason you don't have a microphone or if it's not working, we will come with this one to use. Okay, so now that all that is out of the way, I want to introduce our speaker. I'm very happy today to introduce to you Andrew Dannenberg. He is an Associate Director for Science at the Centers for Disease Control and Prevention, splitting his time there in Atlanta, Georgia, and now also affiliated with the University of Washington. At the CDC, he, like I said, he's an associate director, and he's in the National Center for Environmental Health, where he oversees that center's activities related to examining the healthy aspects of community design. He has a new book out, and we're very happy to have him here, so I'm going to turn it over to Andy.
Thank you. Privileged to be here. I do need to update the introduction. I am no longer the Associate Director for Science. I actually retired from full-time at CDC. I'm now a part-time contractor there and part-time teaching at the University of Washington. So it's a little update over the information you had there. What I'll be talking about today are the links between transportation and health. And I will assume that most of you have heard some of this, but at varying amounts. So some of it may be repetitious to what you know, and it may be new for other people here. I want to start. I'm going to assume that a lot of you are not coming from a substantial health background and more likely to be from the planning background, but I think there's probably a mix in the audience. So I want to start with some of the very basics of health and transportation. What is health? The definition we commonly use comes from the World Health Organization, a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. What that means, it includes more than physical and mental health, but includes well-being and livability issues. The factors that affect health come at various levels, and where we choose to intervene will affect how many people and how those interventions make a difference. The smallest impact, and what we spend a lot of time on, are at the top of the pyramid. And that would be, we educate people for healthy behaviors. We do clinical interventions to treat an individual disease, typically help one or a few people at a time. As you go down this pyramid, we reach the parts that start to make a bigger difference on the population level. So the third one down, a long-lasting protective intervention, might be something like putting up a guardrail on a road or a airbag in a car. But the fourth one is the one that I'm going to focus on, which is if you change the context, which affects people's decisions, you start to make a long-term intervention in their health. And at the bottom, probably most important but most difficult to work with, are changing the societal, socioeconomic factors, alleviating all of poverty, and areas such as that, which are critically important but relatively difficult to do. Looking at health and transportation, the World Health Organization has spent some time on it. and came out with a monograph with the documents the links between transportation, environment, and health. They acknowledge, first, that transportation is a critical part of life. It provides access to goods and services, opportunities for mobility, for a better quality of life, and an important role in economic development. Transportation is essential in society. You all know that. There's no surprises there. They further acknowledge that motorized transport, while it is a major part of transportation, also has some environmental and health consequences that are inherent to using motorized transportation. And they suggest that policies on transportation, environment, and health should be better coordinated and integrated. That is, the two fields should be talking to each other, which is really what we're here to talk about today. How does transportation affect health? There's a long list, and I'm going to talk really more about one than anything else on this list. The three big ones are physical activity and obesity, air pollution, asthma, and respiratory disease, motor vehicle crashes, pedestrian injuries. They're the ones that I think are probably the most important interactions between transportation and health. The other ones on the list, each of which could have a talk on its own: noise issues, water quality, climate change, mental health, social capital, environmental justice, all very important issues. All of them transportation has impacts on. Of the top three, the second and third ones are commonly recognized in the transportation world. Air pollution has been around for a while. We have lots of regulations on it. I think most transportation planners, builders, developers are quite aware of what the air pollution regulations are, how they can be mitigated when a proposal is threatening for air pollutants. And I think there's very good awareness in the transportation world of air pollution as it relates to transportation. Similarly, I think motor vehicle crashes, injuries, the word I think commonly used in transportation is safety rather than injuries, but their injury is more a public health term, that they're very much in parallel. I think there's very good awareness in the transportation world about injuries and safety. We have a National Highway Traffic Safety Administration. We have lots of regulations on how we build cars and how we build roads and guardrails and divided highways and traffic lights and crossings, and a fairly large infrastructure and awareness of safety issues in the transportation world. And so I don't need to go into any detail on the injury aspect per se of how transportation affects injuries. The first one on the list is what I really want to spend most of my time on today, and that is that transportation choices have a major impact on physical activity and obesity and all the health consequences of lack of physical activity and obesity, which is epidemic in this country. And some transportation planners get it and would consider that important in their choices, and others think it's really not part of our mandate. There's no requirements that we do much with that, and give it little attention. So I want to focus on why, from the public health point of view, if the second and third ones there already are receiving a reasonable amount of attention in the transportation world, I'd like to see the transportation world pay more attention to impacts of transportation on physical activity, obesity, and the health consequences associated with them. Just to say very briefly a little more on the asthma and injury, and then I won't come back to them. We do have some information showing links between air pollution and asthma. So, for example, in the 1996 Summer Olympics, there was word in Atlanta, where traffic is usually horrendous, that the traffic was going to get substantially worse during the Olympics. And in fact, people decided to drive less because their word was everything's going to be gridlock, worse than usual. So during the Olympics, the traffic actually went down, the peak ozone levels went down, and asthma-related emergency room visits for children decreased during that time while traffic went down. At the end of the Olympics, traffic went back up, asthma went back up. And we know that it wasn't just kids going away, because the emergency room visits for other causes were the same during the period. So we have some evidence, and these are hard to do randomized controlled trials. This is a natural experiment to try to document that if you fix air pollution, you will have positive impacts on respiratory disease. Similarly, with injury, we know that it is a leading cause of death among young people. major toll, large numbers of deaths, non-fatal injuries, and costs over time. So these are areas for which we actually know a lot. We do a certain number of policies related to preventing injury. So we put up speed limits. And does anybody know where this picture was taken and when it was taken? Go ahead. Montana, the only state in the nation which decided in the 1990s that why do we need a speed limit if we simply say reasonable and prudent? And of course, reasonable and prudent to you and to me may or may not mean the same thing. But we do have policies that were created for injury reasons. Eventually, they did go back to having a real speed limit. And at the time this sign was up, they had the highest death rate in the nation for motor vehicle injuries. Anyway, so let me go back to physical activity and obesity, which will be most of the talk. Why do we care about physical activity? And you probably know most of these areas. A sedentary lifestyle increases the risk of overall mortality, of heart disease mortality, certain types of cancer, all related to inactivity. The effect of low physical fitness is comparable to the other major cardiovascular risk factors such as hypertension, high cholesterol, diabetes, even smoking. So inactivity really is a major contributor to poor health outcomes. Similarly, obesity, and I want to just clarify that physical activity, inactivity, and obesity are not the same but are substantially overlapping. So that obesity is related to similar overall mortality, cardiovascular mortality, but also areas such as diabetes and gallbladder disease that are less related to activity and more related to obesity. The two are substantially overlapping, but do have some differences between them. Obesity is an epidemic. You probably know that. Many of you have seen these slides. I'm only going to show you two of them. There's a series of about 20 slides from CDC that show the changes in obesity by state over a 20-year period. I'm going to show you just two of them, 1995 and I think it's 2010. You'll notice in 1995, the color of this map is a light and a dark blue, which says that the states in the U.S. were basically between 10 and 20% obese in each of the states. If you show all 20 slides, you start to see these colors change year by year. How many of you have seen the whole set of slides? They're fairly well circulated. Here's 2010. Nobody is under 20%. We've had to add new colors, and we're up to a number of states that are over 30% obese. It's a major issue, and transportation is one of the contributors. We're not saying transportation is the center of everything, but it's certainly one of the contributors. Physical activity, food, a whole range of issues that do contribute to obesity. What determines physical activity in one study, and not that different from what you find elsewhere? People are more likely to be active when it's convenient, when places are accessible, when it's attractive, when there are sidewalks, when there's other people to do it with. And less likely if there's not much time, they're too tired, not motivated, or they perceive crime and danger, or no place to do it. So it's make it convenient, people do it. Make it inconvenient, they're less likely to do it. Part of this is community design. Community design includes both how we use our land as well as transportation issues. Those two are really quite closely connected. This is a diagram from Dwani Plater-Zyberk that's been used a lot, that shows classic suburban development where we do what's called loop and lollipop, and essentially houses put on streets that are separated from everything else. The apartments are separate, the mall is separate, the school is separate. The only connections between them, basically you would have to go a long way out to a major road, may or may not have sidewalks, and then into your other destination. And in fact, in that type of development in the suburbs, the norm is to drive because very few destinations are accessible safely by any other means. The alternative are traditional neighborhood designs. You can have in the same amount of acreage the same number of buildings, houses, malls, schools, and apartments, but by having a grid network, everything is more connected and the opportunity to walk or bike is there where it was really absent in that other design. You can see this flying into almost any major city in the suburbs where you could have two kids who live literally 100 yards apart but could have half a mile or a mile between their houses by accessible routes. We also have designs which just aren't made for people and bicycles and anything other than cars. So here you have a set of houses. It looks like a reasonable set of gridded streets so you could walk there. And the shopping center isn't that far away, but then you put in a boundary that is not very crossable. And so people may end up driving a short distance on that. We also have design issues on things like parks. Parks are wonderful. What a great way to promote physical activity. But even how we design the park matters. Here's a park in suburban Atlanta on the left, designed for people to drive to it, with really no safe, accessible biking or walking, even if you live nearby, as compared to the one on the right where you can see houses in the background. People can walk out the door and go use the park. These are transportation designs.
That was Park Blocks in Portland.
Which one?
The one before.
Was it? Okay. All right. There are a number of Portland slides in there, and that is not just because I'm in Portland. It's because you have some of the best examples in the nation. And when I give talks in many places, Portland is often very prominent in the talks as you have some of the best examples. So, okay, I didn't even know that one was Portland. You'll see other ones that are Portland. The one on the left, what was the design there? Was a sidewalk put in, and then the utility came along and said, okay, we'll put our pole where we need it? Or was the pole put there and the sidewalk people didn't figure out how to get around it? But you think about it, would you ever put a pole in the middle of the street and just say, well, the cars will find a way around it? I mean, how did that happen? I don't know how it happened. But it shouldn't, and it's not that rare to find places like that. Similarly, that wonderful cloverleaf is terrific for moving motor vehicles. Can you tell me where you would want to go running or biking, or how well that's set up to put any kind of transit? I see some green space, utterly unusable. I wouldn't want to use it even if I could get to it. That's a land use choice that is made efficient for one purpose and very clearly not for other purposes. We have other places where transportation design is absolutely superb and was done for the purpose of accommodating all users. The term complete streets that we'll come back to. In Charleston, South Carolina, they replaced the old bridge that you can see in the background there, hadn't been torn down yet, with a new one, had a big fight over should we put a walking and biking path on it. Eventually they won and got the walking and biking path. After all, no one's going to use it. It's 3 or 4 miles. Nobody walks or bikes that far. Yeah, it's going to sit there empty and we'll waste millions of dollars building it. Well, they build it, and it is now so popular they are fighting over how much parking to build at the end. It's become a destination where people go distances just to walk and bike on this spectacular walking and biking path that's there. We get places like this. We can pass rules that say Americans with Disabilities Act says we will have a curb cut. We pass another rule that says every property owner should put a segment of sidewalk in front of their house, and no one says, hey, maybe they should be connected. How does that happen? And yet that's not uncommon. We got pictures like that from many places. There's an absence of coordination, obviously, that would even happen. Can you imagine a couple of roads that would sit like that would have space between them? It just isn't going to happen on the roadside. Why is that allowed to happen on the pedestrian bicycle side? One of the areas where there's a lot of promise is children walking to school, safe routes to school programs. The federal transportation bill, the old one, we're waiting to see what happens in the new one, had hundreds of millions of dollars for safe routes to school. Safe routes to school, I think, is a critical foot in the door of trying to improve pedestrian bicycle infrastructure. The major barriers to kids walking to school, according to parents, are distance and traffic danger. Distance is entirely based on where we choose to put our schools. Do we put them out in the countryside near nothing, or try to get smaller community schools? Traffic danger is something, any of you are traffic engineers, we know how to make it safe for pedestrians and bicycles if the political will is there. Here's a school that is outstanding in its field. The number of children who will ever walk to that school is very close to the number 0. Yet somebody chose the land was cheap. It's met the needs without looking at what does this do to the physical activity of the kids who will go to that school. This picture gives an idea of the benefits of safe routes for school, the whole range of kids being able to walk there, carbon dioxide emissions, the physical activity, the air pollution, social capital. Physical activity actually both prevents and treats depression. Now, the reason this is in black and white, it was the last time anyone was known to walk their kids to school, which was before color pictures had been invented. We did some looking with GIS at some of the benefits of safe routes for school. And what we did here at St. Paul, Minnesota on the one side is if you drew a buffer around schools and use safe routes for school money to improve the areas around the schools, in places where schools are relatively close, you end up helping most of the community, because obviously if you put in a sidewalk just for the kids, you're helping everyone else who lives in that area. As you get to more rural areas, as you can imagine, you're helping smaller areas. So the Safe Routes to School I see as one of the very nice foot in the door kind of approaches to get some transportation money that actually helps more the active community design. There is an issue of behavior, and what we know is that you can give people places to be physically active, but it still is a behavioral choice. This is a park in Columbus, Ohio. Turns out it's not quite as bad as it appears, that the woman driving the car, the dog is a show dog who apparently needs more exercise than she's able to do, so that's why she's actually walking the dog out of her car. But it raises the issue. From the health education world, there's a saying, make the easy choice the healthy choice. And so we need the designs that encourage the walking and biking. And then you need, people still will make their own behavioral choices. Here's the other one, the same kind of issue, where you have an escalator next to stairs. And again, and this is going into a fitness center, people using an escalator when the stairs are available. There's a lot of design issues in a setting like this, that when you put the two next to each other, the choice becomes kind of equal, that people can go either way. When you start to make it so the stairs are in front of you and attractive, and the escalator and elevator are kind of hidden out of the way, a little less pleasant, then people start using them more. And we certainly have any number of buildings where the stairs have been made to be very attractive and day-lit, and so the grand staircase approach. And you find the usage goes up when you make it attractive for people to use them. Walking and biking, we know from international experience that we can make a difference in how much people walk and bike. And this was a study by John Pusher at Rutgers from a few years ago, looking at the US and Germany and Netherlands, and proportion of trips walking and biking substantially higher in Europe, where they have built the infrastructure so that you have a choice, and a lot lower in the US. And injuries actually are related to building that infrastructure, so that the injury rate per 100 million trips is substantially lower in the European countries, where they have built infrastructure that both encourages the biking and walking and is made to be safe for the users of biking and walking. This slide comes from Portland, because you actually have the best data that we have seen anywhere showing if you build it, they will come. And these are your data. I think this only goes up to about 2006, and it basically continues from there, that as you have built bicycle infrastructure here in Portland, the usage has gone up with some very good bike counts on your bridges here. We have lots of ways to develop things, and if you look at the top and the bottom pictures, the top picture, just on visual appeal, is a place that you would essentially want to get through. You get there and you keep moving. Whereby the bottom, which could be a recreation of the top, starts to add things that make it it's placemaking, make it a place you might want to be. There are places to walk, there are shops to look in, there's some green space, there's transit options. And how you design a place can make it attractive to want to be there or not be there, and transportation is certainly part of that. Public transit can be and should be a major part of transportation systems. I live in part in Atlanta, which has basically failed to invest in public transit, and I come to a city like this where you have wonderful investment in public transit. There is a close link between public transit and health. Reduced car use can help air quality, can reduce injuries. The physical activity, transit involves use of physical activity. I'll come back to that in a second. And there are multiple health benefits of choosing such things as transit-oriented development and smart growth principles. Again, a Portland picture, which I use routinely. We looked at how much walking is involved in use of public transit. And there's some great data from the National Household Travel Survey, about several 100,000 people, collect data on them for their travel, and of which there's about 3,000 transit users. This is the 2001 data. We're in the process of looking at 2009 data, and found that transit users walk a median of about 19 minutes a day getting to and from transit, because most transit trips begin and or end in walking. Even if you drive to one end of it, chances are you're going to walk at the other end. And about a quarter of all transit users walk at least 30 minutes a day getting to and from transit. So it's actually one of our stronger links between the built environment and health, is that transit, which is a built environment issue, and physical activity, which is a health issue, are very closely tied. This also gives us some numbers so that when we'll be talking about health impact assessment in just a minute, that what are the health impacts of building a transit system, we can go to data like these, which are nationally representative, and say, here's some of the positive health impacts of building a transit system. Some of the other approaches, again, it's an Oregon law, complete streets, that says you're looking out for all the users of the street, and Oregon was one of the leaders in putting such a law on the books. We have some other tools. One that's in the last few years that has really been fascinating to use called Walkscore. How many of you have seen Walkscore? Okay, most of you. Wonderful computer-based GIS tool came out of some very smart young people in Seattle, which takes a Google map and says, give me a location and I'll tell you how close you are to other destinations, and gives a score of 0 to 100 of any particular destination. And you can look up your home address or wherever. You go to a very urban area, you get a very high walk score. You go out in the middle of nowhere where there are no destinations, you get a very low number. One of the potential uses of Walkscore, which I'm fascinated by because it's one of these long-term investments that could over time start to influence behavior, is that Walkscore can be added to real estate listings. And in fact, there are some websites, Zillow and Windermere and a few others, that already have Walkscore on them, so that a home buyer looking at, I want 3 bedrooms and 2 baths and whatever characteristics, can say, I want a place that's walkable, and be able to look at that walk score between 0 and 100 and say, hey, it's got a walk score of 20 or 30. That's going to be very car dependent. Maybe I'll keep looking, or put it in as a criteria. If it has to have a walk score of at least a certain level of walkability, don't even show me it on the list. And other settings that are quite walkable. So just having a tool like that potentially could influence behavior as you put that information in front of people. Okay, what I'd like to do is spend the last amount of time, which I think is about 15 minutes, on a tool that we've been spending a lot of time on called health impact assessment. And where this came from and where we're going with it. One of the issues we found in looking at health and built environment issues and in transportation issues is that lack of communication between the health world and the planning and transportation worlds. We speak somewhat different languages. Health people don't know a lot about planning and transportation fields. Planning and transportation people generally don't know a lot about what the public health world does. And out of a look at how could we approach this, the concept of health impact assessment, which has been used in Europe for a while, arose as a tool to help build partnerships and communication between the public health world and the land use, transportation, and planning world. The vision would be that planners in transportation, land use, elected officials, and others who make decisions would want to know something about health consequences of their decisions as part of that process. That health officials would have a tool with which to convey that information, and that it helps bring public health to the table so it becomes part of decisions. Formal definition of health impact assessment. This is recently revised. There's a report that came out a month ago from the National Academy of Science, National Research Council, that says HIA is a systematic process that uses various data sources and analytic methods, gets input from stakeholders to look at the potential effects of a proposed policy, plan, program, or project on the health of a population. So what are the possible health impacts of something that's being proposed, and the distribution of those health impacts, so we can look at social justice, environmental justice, social equity issues. And how can we make recommendations on a proposal that can be considered and potentially improve that proposed project or policy or plan so that it make more favorable outcomes toward health. So either you want to encourage the things that are already favorable to health or mitigate those that are adverse to health. Major steps in conducting a health impact assessment include screening, which is, are there health impacts worth looking at? Should we even go ahead with an HIA? Scoping, what health impacts should we look at? Risk assessment is which people will be affected and how. Recommendations are, what can we do about it? What recommendations can we make on this proposal that will improve it from a health viewpoint? Reporting is conveying that information to those decision makers. And then evaluation and monitoring, what difference did it make that we had done this HIA? A couple of issues come up immediately on use of health impact assessment. And the first one typically is, should it be regulatory or voluntary? A voluntary health impact assessment, and most HIAs that have been done in the US so far have been voluntary with a few exceptions, are simpler, they're less expensive, they're less litigious, and more politically accepted. What it is the health world conveying some information to transportation or other decision makers saying, here are some of the impacts that your proposal has, here's some suggestions for how to improve it, consider them. Nothing regulatory, nothing required in there that obligates the decision maker to use it, but because of that, it is less likely to be used because it's not required. But it's easier to do and it's cheaper and more acceptable. The alternative, which is modeled on environmental impact statements that I assume you all have heard of, is to have it required. It becomes more complex and expensive, becomes more litigious. I was told at one point that to write a statement under a regulatory environment, then every sentence shall be legally defensible. I can't write a whole lot of sentences if I have to meet that standard, because that's a very high standard for anything you say, whereby one that doesn't need to meet that standard can say, my professional judgment says the following, is a whole lot different from legally defensible. The problem with the regulatory environment is there's certainly not great political acceptability of adding more regulations, but it would get used more. The relationship between health impact assessment and environmental impact assessment is very important. Logically, health can fit into the existing environmental impact statement process under the National Environmental Policy Act, 1970, NEPA. The actual wording of that law talks about health, and in a way that you can incorporate health into the environmental impact statement process. And we do have examples where health has been successfully incorporated into the EIA process. So it can go that way. And that report I just mentioned from the National Research Council, one of the recommendations is we really want to get health more into the environmental impact statement process as one way to promote HIA. The typical example that has been the issue is that EIA will look at something like, say, air pollution and say that this project will change parts per million of a particular air pollutant from this level to that level, and never give the next sentence, which is the health sentence. Air pollution itself is not a health issue. Air pollution's impact on asthma, respiratory disease, that becomes a health issue. And typically, the environmental impact statement doesn't give that next sentence. It says, here's what it does, how many more extra cases of asthma, for example, will occur because of that change in the air pollution level. The other issue that comes up regularly with health impact assessment is whether to be quantitative or qualitative. There are a lot of health issues for which qualitative is very doable and quantitative is very difficult. The models don't exist and would be hard to do. So for example, build a sidewalk, people will walk more. We know that. We have plenty of evidence people are more likely to walk when you give them access to places to walk. As soon as we say we want quantitative, build a sidewalk and 300 people who live within 200 yards will walk an extra 15 minutes a day and they'll lose 7 pounds, will prevent 4 heart attacks over the next 6 years. We don't have models, and I'm not sure they're even doable, that would be reliable to give you that level of modeling. And yet there's pushback, because if you want to do a cost-benefit model as part of your project decision, you need that model, and yet the model may not exist. So we're kind of caught between a rock and a hard place on what to do about quantitative and qualitative. My personal bias is qualitative is really conveying the same basic information. Certain things are favorable to health, certain things are not. And to the extent we can, within reason, go for the ones that are favorable to health, but we are not likely to get you the great models that would be ideal. They're just not really doable. I mean, how many people will walk on a particular sidewalk is a factor of so many issues, of where it is, what it connects with, do you feel safe, what, is it aesthetically attractive, how far is it to destinations, on and on. I mean, there's so many factors there that we really don't have that modeling ability, and I'm not sure how doable that is. HIAs have been in use around the country. As mentioned, there are many hundreds of them in Europe. In this country, we have 100 or so. West Coast, including Oregon, have been among the leaders in doing HIAs, but it's really caught on across the country. There's not a lot of funding. There's been funding particularly from Robert Wood Johnson Foundation. Some foundations, CDC has funded some. Some have been done by voluntary groups. Some have been done within health departments without extra funding. But we're in the ballpark of 100 or so completed HIAs at this point. Examples of the kinds of HIAs that have been done for transportation projects include the 520 bridge in Seattle, the Columbia River crossing here in Portland, some other freeways, transit projects, the Lake Oswego transit project here, corridor redevelopment, including, I think it was Highway 99 in Vancouver across the river, Oakland looking at a port, greenways and trails. So a number of transportation-related HIAs have been done, mostly voluntary. The one exception there is the State Route 520 bridge replacement. Seattle actually was legislated in the money for that bridge replacement. The state legislature said there will be an HIA for that. It was the first time in the country that there had been one. The one newer step on transportation-related HIAs is the state of Massachusetts recently passed what's called the Healthy Transportation Compact, which actually mandates HIAs for transportation projects in Massachusetts. Brand new, not been done anywhere else in the country. And we are in the process of waiting to see how that will be implemented in Massachusetts. Obviously, you don't want every time you fill a pothole to need an HIA, and every big project should have one. And so what that will look like is still unknown, but it's a step forward into having health at the table in transportation projects in Massachusetts. There's also HIAs of various policies, which have included such things as in California, looking at redirecting transit funds, walk-to-school programs, a nicely done one here looking at reducing vehicle miles traveled, some community transportation plans and airport operations policies. So it's been used for both projects and policies in transportation. And a couple of examples, and then I will wrap up and have time for questions. The redirection of mass transit funding in California was the state legislature was looking at using transit funds for other purposes. UCLA School of Public Health looked at a number of issues of why having less transit really is bad for health. Transit, parallels many good health outcomes, and reallocation, losing those funds would have adverse health outcomes. The problem was that the timeliness really matters, and the state legislature went ahead and redirected those funds before the HIA was complete. I think there were some subsequent battles over it, so I'm not sure where it ended up, but timeliness really matters in doing an HIA. It needs to be not too late when the decision's already made, but also not too early when too little is known about what the details are. The one mentioned here in Oregon, looking at vehicle miles traveled by Mel Rader, found that the optimal choice for health benefits would be a mix of land use, increasing the cost of driving, and increased investment in public transit. Another one here in Oregon in Deschutes County was looking at a community plan and looked at some of the safety measures for pedestrians and bicyclists, and some of the suggestions out of that HIA were in fact incorporated into a revised plan adopted by the Board of County Commissioners. And then in Atlanta, we had a major HIA on what's called the Beltline project, which was some unused rail lines going to be turned into light rail parks and transit. Some of the benefits of that is because it had trails and parks and transit, had quite a few positive features in it, so that the HIA basically said this is good, encouraged it to move forward. And there have been a number of positive steps as that project has moved forward, and the HIA did help contribute to encourage a good project to go forward. So HIA is not just to stop the bad stuff, it can also be used to encourage the good ones. And then just a couple minutes, and I'm about out of time, on the bridge replacement in Seattle. This was, as I said, a mandated one. It was to build extra lanes as well as bike and pedestrians and safety shoulders. Scoping issues had the whole range of health issues, injuries, physical activity, noise, social equity, and so forth. Stakeholders, quite a range of stakeholders on the neighborhoods, on the wetlands, on the commuters who use it, quite a range of stakeholders. So you really do want community input, and it's a range of stakeholders who need to be part of that community input. And some of the recommendations that came out of that, and its project still, the final designs are still underway, looked at such things as landscape lids that would provide some green space crossing over the freeway, various transit and biking and walking recommendations. We do know some about impacts of HIA. We have a number of HIAs where they've made a difference. So various places where road corridor plans were improved, that some of the recommendations were incorporated into the environmental impact statement process. The big thing on HIAs is that they do often raise awareness of health issues, even when you can't always point to exactly what the specific change made was. Some we can say the HIA caused a particular change. In other cases, the raised awareness is a little bit softer, but we know it was in the right direction. We get settings like this. This was an Atlanta proposal for a 23-lane highway, which from the transportation point of view, I'm sure, extra lanes will temporarily move more cars faster. But how do we get a proposal? If 18 lanes isn't doing it, do you really think 23 lanes is going to make the slightest bit of difference long term? How do we get health at the table so the proposal, my narrow point of view is, why should something like that ever even be proposed in a city that has abysmal mass transit to start with? If you can fill up 23 lanes, why don't you build the mass transit? You obviously have enough people who could use it. Anyway, whole set of issues there. But how do we get health considered when proposals like that come up? Just one quick sentence on links between health and sustainability and green, and that is there's substantial overlap between what is sustainable and what is healthy, but some things are one and not the other. So using public transit, biking, walking to work, taking the stairs, a range of things are both sustainable, environmentally friendly, and healthy. There are also other issues that are primarily one or primarily others. If I get enough exercise, it doesn't make that much difference to the environment. If I recycle newspapers, good for the environment, not a major impact on health. But there's substantial overlap in sort of the green agenda and the health promotion agenda. Final thoughts, and then to get to discussion. We know that transportation affects health. Lots of co-benefits, that good design can affect obesity, climate change, environment, mental health, social capital, social equity, whole range of issues. How do we get there? How do we make a difference? And just I'll run through these in one sentence each, but any of them open for discussion. We need people with that interdisciplinary education, and I think you've started some of that here. It's happening elsewhere in the country to get people training in both public health and transportation. Health impact assessments, moving them forward, as you heard, getting more health into environmental impact assessments. More research on documenting that it makes a difference. Working with comprehensive plans to get health elements into them. There's a whole series of work on that. LEED, many of you know, for energy efficient buildings. There's something called LEED for neighborhood development that is very much promoting healthy communities as part of where it's headed. Working with things like multimodal level of service indicators, for those of you who are used to the motor vehicle level of service indicator. Well, there's a set of ones that look at all users, the bicycle and the pedestrians, as well as the cars, and that can start to make a difference when that's built into projects. And then issues on such things as walkability audits and inventories, and just approaches that start to get the broader picture of what transportation can include. We have a book out, happy to pass that around, that looks at a lot of these issues, published last month. And let me stop with that. Two websites just to mention, and again, a Portland picture in there, of course. We have a Healthy Places website at CDC that has a lot of this information and lots of links to other places. And then Health Impact Project is a Robert Wood Johnson Pew Charitable Trust funded group that is supporting a lot of HIAs around the country. Let me stop with that, and happy to have questions for the rest of the time. Thank you.
Use your microphone, or I'll bring one to you. Questions?
Yes.
As far as, for example, here on the right, you have roadways that you can possibly mediate and rework, but what do you do as far as an urban framework, as far as communities that are already designed in place and perhaps, I guess, written off? I would say that would be something that you come back to after a couple generations when demand has changed, but what do you do for the chronically impoverished or unhealthy that exists there now?
Very good question. We have tremendous investment over many years in the existing infrastructure that's out there. And obviously you can't go back and change everything right now. I think the best answer is every day and every week there are decisions being made on what the next development or redevelopment will be. And it's a matter of aiming those decisions toward a more favorable, more healthy environment. Places do get redeveloped over time. I'm not going out and saying, let's go tear down something that wasn't going to be torn down otherwise. But when a place is being redeveloped, and now with a bad economy, it's certainly not as much going on, but development and redevelopment is ongoing over the years, and most any place at some point will eventually be developed or redeveloped. And so it's at those decision points to try to intervene and not expect that you will change everything right now that's already existing. Yeah.
With
more people participating in the cycling initiatives or walking initiatives, this means that they're in closer proximity to each other. Surely this would create an increase in contagious diseases or illnesses or whatever.
Question is, as you have more people walking and biking, are you increasing risk of interactions and contagious diseases? Potentially, and I'm thinking less the walking and biking in fresh air and more of the crowded subway where everyone is, pushed up right against each other. I think I've seen a few reports of, certainly in flu season, everyone coughing and sneezing in a very tight place. There is some risk there, but I would say longer term you have much more health promotion out of going that way and taking that risk in high flu season, people wearing masks and changing the behavior somewhat then. But I don't see it as a major risk when you consider the very high morbidity, mortality of long-term chronic disease that this addresses. Yeah.
How much does it cost for an HIA, and how long do they take?
Good question. The cost of an HIA is anything from a few dollars and a few hours of a maybe health officer doing a desktop HIA, reviewing your proposal and putting in a few suggestions, to ones that have cost hundreds of thousands of dollars. The basic cost is going to be kind of time and resources available and level of depth. In some cases, a multi-million, multi-billion dollar project, it makes sense to invest $50,000 or $100,000 into an HIA. If you make them regulatory and get to that standard of legally defensible for every sentence, you clearly will drive costs up. What we have seen is that they come in all sizes and shapes, from, as I say, the desktop version to the ones that take a year or more and cost substantial money. My bias is simpler is better because it gets done. And we have some examples of places that have basically used a checklist to look at the health issues on a project, very minimal amount of time and money, and it raises the awareness and can improve some areas. So the range is all over the place. I think simpler is better because it's more likely to be done. Yes?
You mentioned the Europeans have been doing HIAs for a much longer period of time, have done many more of them. What have they learned? What's been their experience, and how come they've been doing it longer, more frequently than we have here?
They've been doing it for a long time. We have learned from them. Much of the published literature is from Europe. I've been to a number of the international conferences to get to know the leaders in Europe on this topic. Not sure where it actually originated in Europe. England is certainly one of the major leaders. A lot has been done over there. I think we're all kind of gradually learning what works well. They have slowly written it into some of the both local and national and European Union regulations for how to use it. I think over time it has been helpful, but right now we actually have a project funded by Robert Wood Johnson Foundation looking at U.S. Completed HIAs. How well can we document what difference it has made? There's some literature from Europe that has tried to evaluate what difference does it make. There's a book out by Matthias Wismar that comes out of the European Office of WHO that looked at HIA in something like 17 countries in Europe and found the whole mix. I mean, the mix of where it really made a difference, some places where it really got ignored by the decision makers. It varies as to how much impact it's had, but we do have a good bit of contact with the Europeans who have been leaders on this. Why it started there, not here, I'm not sure. It's kind of looking at those issues of diffusion of innovation that are always fascinating to see how ideas travel. Yes?
I would like to know how important is education regarding transportation and health here in the United States, and how do you use it? Where do you invest on it? Which level of school? Like, do you start from elementary? Because we had a project in Netherlands this summer, and they told us that they educate their elementary students in order to get a certification for bicycle riding. So I want to know, how does it work in the U.S. regarding that?
Interesting to hear they would have that in Netherlands. I am not aware that there's that much education about transportation and health anywhere along, younger or older till you get to graduate school for those who have chosen to go that direction. I don't know of it being particularly focused on. So I think the amount of knowledge on that is sort of very slowly getting there at the graduate level as schools such as this become more aware of those links. At this point, what exists across the country, there's probably half a dozen to a dozen schools that have some type of integrated built environment and health course. And there's about 6 schools that I know of, plus the one here and one in Philadelphia, that are looking at creating health impact assessment courses. So it's gradually getting out there, but it's certainly not widespread or talked about that much. Yeah.
So we have one question from one of our web viewers, and it was partly in reaction to the photo with the escalators next to the stairs and the idea of making it easier to take the healthier choice. And the question has to do with what about ADA, Americans with Disabilities Act, and potentially some conflict between needing to meet those requirements where an escalator or an elevator or something might be necessary.
Americans with Disabilities Act talks about reasonable accommodation for the needs of people with mobility impairments and other disability impairments. I guess I don't really see it as a conflict in that as you make places so the easy choice is the healthy choice, it's not saying get rid of the elevator or the escalator. It's trying to make it so that the attractive, easy choice is the more active choice, but that accommodation for persons with disability is still available. One example that's kind of fun to talk about is there's a building in California, and I think I heard it was a Department of Transportation building, where they made the elevators only stop at every 3rd floor. And from that floor, anybody know about this building? No. When you get off the elevator, there's a lovely, attractive stairway that goes to the floor above and the floor below. And they found that people are quite happy to use it, and they do. And then there is a separate elevator that stops at every floor that's ADA compliant and is certainly available for people who need to go to every floor. But it affects behavior, so that by making the primary elevator one that encourages people to at least walk one floor, they have, apparently it's fairly well accepted for the people in the building. Yes?
You stated earlier that it's trying to make...
Oh, okay, sorry.
Stated earlier that trying to make the easier choice the healthy choice. Is there incentives to make the cheaper choice also the healthy choice? Like, right, I mean, a lot of people would drive somewhere and spend, $5 on gas to get $2 of savings at Walmart because they feel the prices at the local downtown store are more expensive. Do you see any future in that?
Economics drives a lot, and people are looking at their economic choices along with their health choices. And so that my feeling is that as we design choices to try to make it so that it is both economically attractive and health attractive, what we know is that as you make it more expensive to drive, and people will drive less. I mean, every time we have a spike in gasoline, public transit use goes up and driving goes down. And for that matter, motor vehicle injuries go down because people are more on public transit. I think we also know fairly clearly that every time we short our public transit and raise the fares and cut back on service, you're going to lose riders. And so I think the economics need to be consistent. And so then it becomes a policy choice of, are we doing those investments in public transit, in biking, walking, and raising a gasoline tax? Gee, that's heresy. You can't say that. Well, I can say from the public health point of view, a higher gasoline tax and use it to subsidize public transit is favorable to public health. Yes?
I just have a question about the general sentiment that you encounter when you go and talk in the public. Are people fairly skeptical that their transportation choices have an effect on their level of activity?
Are people aware that transportation affects their health? I guess I have to say some people are and some are not. Some will not have thought about it. That well, it's just part of my daily life that I spend, an hour a day, driving to my job or whatever. I met a woman the other day, and I live on a bicycle. I rarely drive, so I think, coming from a bit of a bias there. But a woman who was riding the subway who spends an hour and a half every day between, two buses and the subway, and that's just part of her daily life. I'm not sure what she did. I suspect she did not have a high-paying job, that she had a choice, but part of her daily life was this is what she had available to get to whatever job she had. I suspect most people don't think about it. They do use the excuses, I don't get exercise because I don't have time, because I'm in the car too long, but not necessarily thinking about, well, maybe if I had chosen where to live to reduce that commute time, or chose where to live so I had some options other than driving, that becomes part of their choice. So some of this is raising awareness. My guess is that most people aren't particularly thinking about transportation as linked to health. Yes?
So there are public meetings for when there's an HIA health impact assessment going on.
Question is,
sometimes
go ahead.
Made public, and is that a way for community members to get involved as stakeholders?
Are there public meetings related to HIAs? HIAs do not have a standard at this point, so they really vary. Environmental impact statements routinely have public hearings as part of the process. When HIA is done in conjunction with EIA, then often those health issues can show up at the environmental impact statement hearings. It will vary by who is doing the HIA, and of the 100 or so we have, some will have had public input, some will not, some will have a web-based way of collecting information, some will have held public hearings, some will have gotten them under the EIA process. But since there's not really a standard for doing it, community input is always desired, it's not always obtained, and so there's not a routine, there's always a public hearing for an HIA the way that it exists for EIA. Yeah.
I guess I'm from Montana, where that sign was at, and so
that's why you knew.
Yeah, it's pretty libertarian, and what I've come across there a lot, and I guess maybe how do you come across this politically in the political landscape we've had with the Tea Parties and stuff? Yeah. How do you respond to people who say you're just trying to tell me what to do with my life, and it's my life, I can do whatever I want to do with my land, and if you come in, you're being disruptive?
Yeah. There is definitely going to be pushback really for all of public health from a libertarian viewpoint. Why should government tell me anything about vaccines? Why should they, set standards on, the flow of the water in the toilet and all these other areas? And you just get pushback from a libertarian point of view that what's the role of government? And I guess I have to say public health is used to that we try to look at the greater good at reducing morbidity, mortality over time. And I expect that. So I don't know that you're going to convince a libertarian that to change how they're thinking. We can frame the picture differently. I think the framing is important. And part of it is that giving people walkable communities should be a choice. We're not telling them you've got to live there. We absolutely think there still should be, cities and suburbs and towns and rural areas, but we want to have those choices of more walkable areas, and we want to be consistent with the market. And from what we do know of various surveys, there is demand for more walkable communities out there than are currently supplied. If you ask people, would you like to be in a walkable community, and are you in one? You find there's actually a fair number of people saying, yes, I would like to be in more walkable places, and no, I'm not living in one for whatever all the reasons of economics and distance and so forth are there. So it's framing it as choice and saying that good planning, is what planners do, can give a health-promoting environment, but not telling anyone where they need to live. We're not taking away cars. There are certainly some jobs, the salesman who needs to make multiple calls has no choice, or the plumber who needs to carry his tools. No one is saying carry all your plumbing tools on the mass transit. That's, no one is saying that ought to go that way. But you still could give that plumber a whole lot better trip on the freeway if the people who didn't need their cars had some alternatives and freed up some of that space on the freeway. So there are ways of framing it that society overall can benefit when you give some healthier choices out there.
We're at 1 o'clock, and I think that's probably a good note to end on, the theme of choice.
Okay.
Before we thank our speaker today, I do want to let everyone know that next week we'll have Christopher Garlick from Atkins, North America, talking about gasless and cashless take a toll, sustainable and nonstop mobility through user fees. So hopefully we'll see some of you there. Thank you very much.
Thank you.